Okay, thanks very much. I'm going to talk about the drugs that are prescribed for mental health problems. So that includes things like depression, schizophrenia, anxiety, and bipolar disorder, and other things. I'm used to talking to an audience that are particularly interested in mental health, so I will try and explain terms. But if there's anything people don't understand, just wave your hands around and I'll try and explain it a bit further. So I want to emphasize that I am a practicing psychiatrist and I do prescribe drugs, and I do think that sometimes some drugs can be useful. What I'm going to try and put over in this talk is the idea that we really profoundly misunderstand what they actually do. And because we misunderstand them, we are not using them wisely, and we're probably causing a lot of harm. So I want to look at the assumptions that underpin the current view of what drug treatments for mental health problems do. I want to suggest an alternative way of understanding them, and I want to think a little bit about how and why we have this misunderstanding in the first place. And just to say, the book that's on sale here is The Bitterest Pills, but I've written 2 other more general books about psychiatric drugs, and maybe I would particularly recommend the one in the middle, because it's, if anyone is particularly interested, just because it's a short but quite detailed guide to all the different drugs that are prescribed for mental health problems. So this is the situation recently in the United Kingdom. There is an increase in the overall use of drugs for mental health problems, a substantial increase which is accounted for mainly by a huge increase in the prescribing of antidepressant drugs. When I looked at this data, I thought maybe that might be compensated for by a fall in the prescription of other classes of drugs, but as you can see, that's not happened. In fact, most other classes of drugs have risen as well. So we're using more and more drugs for mental health problems. And for at least the last 20 or 30 years, they have been promoted alongside this message that what they are doing is targeting an underlying chemical imbalance. So there are all sorts of pharma websites that give you this message that antidepressants work by balancing the brain chemistry. I particularly like this one because you've got the picture of the lady in the very balanced position there, just to emphasize the balancing role of psychiatric drugs. And this is one version of the accepted view, the accepted mainstream view that's accepted by the medical profession as well, of what psychiatric drugs are doing. And this is the idea that they are correcting an underlying biological abnormality in the brain. One version of that, one suggestion of that biological abnormality is that it consists of a chemical imbalance, and I'm sure you're familiar with all these pictures of nerve endings and neurotransmitters crossing the nerve endings. There have also been suggestions that it's to do with abnormal neural circuitry, the connections between the different parts of the brain. And this idea is what I've called the disease-centered model of drug action, the idea that drugs are correcting an underlying abnormal brain state. It's a model that we've borrowed from general medicine, where most medicines can be understood to work in that way. So it doesn't necessarily mean that the drug is treating the ultimate cause of the disorder. The drug might just be working on the physiological mechanisms that produce the symptoms, but it's working on some underlying mechanisms that have gone wrong and that are producing the symptoms of the disorder. So an example might be treatments for asthma. They don't, the inhalers that you take when you're wheezing, they don't cure the disease of asthma, but they work on the mechanisms that produce the constriction of the airways that produces the wheeze. Insulin for diabetes, that's often trotted out as a paradigm, as a model for what psychiatric drugs might be doing. In fact, insulin is not curing the cause of diabetes, but by replacing the failing insulin supply, it's helping to normalize the body in some way. And painkillers like aspirin and paracetamol can also be understood in this way. They, again, are not working on the cause of a disease, but they are working on the physiological mechanisms that produce pain. Now, the alternative way of understanding what drugs are doing when we give them to people with mental health problems is what I've called the drug-centered model. And this model is suggesting that, in contrast to the disease-centered model that's suggesting that drugs are rectifying an underlying abnormality, the drug-centered model suggests that they actually create an abnormal brain state. Or to put it in a slightly less aggressive way, maybe, they create an altered brain state. And this is because the drugs that we prescribe for mental health problems are what we might call psychoactive drugs. That means they're drugs that pass the blood-brain barrier and go into the brain and change the brain. And by changing the brain, they change the way that people think and behave and people's emotional responses as well. And what this model is suggesting is that the effects that we see when people take psychiatric drugs, whether we deem them to be useful or not useful, are a consequence of these alterations to normal brain processes. So an example of this model might be the use of alcohol for social anxiety. When I was training as a junior doctor, I was taught that alcohol could be useful for people with intense social anxiety. It wasn't being suggested that social anxiety was due to an alcohol deficiency. It wasn't even being suggested that alcohol was correcting some underlying chemical imbalance. It was being suggested that the alterations produced by alcohol, the typical state of alcohol intoxication, which we're all familiar with, is characterized by social disinhibition. And that could help counteract intense social anxiety in someone who suffered from that. Another example, which I think is useful to highlight, is the use of opiate analgesics. Now, opiates probably do have some direct mechanism, some direct action on pain conduction mechanisms. So they slow down pain conduction. That part of their action is a disease-centered action. But unlike things like aspirin and paracetamol, opiates are mind-altering drugs, psychoactive drugs. And one of the alterations that opiates produce is that they cause this state of emotional indifference or disengagement. So people who've taken opiates for pain will often say that they still have some pain, but they don't care about it anymore. And that aspect of their action is a drug-centered action, what I'm calling a drug-centered action, to distinguish it from their action on the actual pain pathways. So this drug-centered model of drug action is emphasizing, as I said, that the drugs that are prescribed for mental health problems are psychoactive drugs or mind-altering drugs that produce altered mental states, changes in thinking, emotion, and behavior. But of course, they don't just affect the brain, they affect the body as well. So there are physical and bodily alterations that are associated with the mental alteration. So if you think of, for example, the sedation that might be caused by a drug like Valium, for example, there is both a mental and a physical component to that effect. And we are used to thinking of the term psychoactive drugs in association with drugs that are used for recreational purposes, so drugs that make people feel good, feel high, feel nice. Sometimes they're said to cause euphoria. But there are drugs that alter the way, that cross the blood-brain barrier and alter the way that we think and feel, that can make people feel bad. A psychoactive drug doesn't necessarily need to make people feel good. And many of the drugs that are prescribed to people with mental health problems actually make them feel quite nasty. Now, I think it's important to realize that people have used psychoactive drugs for as long as we have historical records, to alleviate misery and suffering. So this is a picture by the English artist Hogarth of Gin Lane, everyone getting furiously drunk on gin in the 18th century in London. Conditions were really pretty horrible, and it's quite possible that it was just the gin that got people through. There was also, later in the 19th century, there were very high levels of use of a substance called laudanum, which was a mixture of alcohol and opium. And this was widely used for pain, for treating all sorts of illnesses, and given to children quite liberally as well. Cocaine was a popular substance which was widely available until it started to be restricted at the beginning of the 20th century. It was put into this wine, a mixture of alcohol and cocaine, which was endorsed by one of the popes, won the Pope's Golden Award. And of course it was put into Coca-Cola and widely used as a stimulant in Coca-Cola. Now, treatment for mental health problems in the early 20th century was generally regarded as being very non-specific. It was thought that getting people into an asylum, giving them lots of fresh air and putting them to work was what was really going to help people. Drugs were used quite liberally, but they were used on the understanding that they were acting in a drug-centered sort of way as general sedatives mainly. So a whole load of different sorts of sedative drugs like opium and barbiturates were used liberally in these old asylums. And when stimulants came along, when the amphetamines were discovered in the 1930s and 40s, they started to be prescribed as well. And as I said, these drugs were understood at that time, as far as anyone really thought about or analysed drug treatment, according to a drug-centred model. They were understood as causing alterations to normal mental functions. So this is an advertisement for barbiturates, clearly emphasising their sedative properties. And this is an advertisement for amphetamines, emphasising how much more smart and confident and busy you would be if you were using amphetamines. Then mental health treatment started to change in the middle part of the 20th century, and it changed because a number of physical procedures were introduced, some of which we still have. The first one was malarial therapy for people with chronic syphilis. The idea was that if you gave people malaria, the high temperatures would kill off the bug that was causing the syphilis. And the old asylums used to have mosquito breeding areas in order to produce the malaria. It probably wasn't effective and was obviously quite dangerous. But it made the people who worked in asylums feel that they were doing something properly therapeutic and something properly medical. And then another set of bizarre procedures was introduced, starting with insulin coma therapy. And this was the idea that if you gave people high doses of insulin, put them into a coma for a few hours, and then woke them up suddenly with a shot of glucose, that would sort of shock them out of their mental disorder. And it was particularly recommended for people with schizophrenia, so this is a slide of it being given. Again, it was a very dangerous procedure, certainly ineffective. But again, it was really important because people believed it was effective, and not only did they believe it was effective, they believed that it was actually acting on the underlying disease of schizophrenia in one way or another. ECT was another procedure that came in around this time. It was introduced again for the treatment of people with schizophrenia, but gradually it came to be associated with the treatment of people who had what was then called manic depression, or sometimes just very severe depression, usually a sort of psychotic type depression. Again, like insulin coma therapy, there was no clear idea about how it might be working, but there was a sort of feeling that somehow it was working on the underlying mechanisms that produced these conditions. People speculated maybe it was working on the pituitary gland or brain circuits, which comes up and again. So this is important because at the time that modern psychiatric drugs were introduced in the 1950s, psychiatry had started to believe that it had some really effective, sophisticated treatments that targeted the underlying conditions that of the people that it was trying to help. And this was the context into which these new drugs came. So chlorpromazine was the first of the drugs that were introduced at this time, which are still being used, or similar drugs are still being used. Chlorpromazine is one of the class of drugs that we would now refer to as antipsychotics. So when they came in, they were greeted very enthusiastically. Their use soon spread throughout France, as you can see from this slide, and throughout Europe. And in the US, they were introduced by a huge campaign organized by SmithKline French, the drug company that was marketing them here. The chief executive of the company went on national television to announce the arrival of this miracle drug that was going to be so effective. But when they were first introduced, they were not understood as disease-targeting treatments. They were understood as special sorts of sedative. They were still being understood according to that drug-centered model of drug action. And they were referred to in the early days as neurological inhibitors. They were seen as drugs that basically slowed down or suppressed nervous system activity. Later, they were known as neuroleptics, a name that's still used. That means to seize or restrict the nervous system. And they were also referred to as major tranquilizers, which again, I think, captures the alterations they produce quite well. And you can see that this was the understanding from these early advertisements. This is an early advertisement for another early antipsychotic drug, which clearly emphasizes the tranquilizing properties. These properties were thought to be useful for a whole variety of indications, so the drugs were widely promoted for the treatment of agitation in the elderly, for behavior problems in children, and for anxiety in adults. But gradually, over the course of the 1950s and 60s, there develops the idea that they are actually treating an underlying disease in some way, that they're doing something specific, that they're doing more than just tranquilizing people. And by 1970, you've got the idea that they are targeting psychotic symptoms or targeting the underlying basis of psychosis or schizophrenia, and they start to be referred to as antipsychotics. A similar thing happens with antidepressants. The first drugs that are thought to have antidepressant properties are actually stimulants. It's quite clear from the first accounts of their effects that they're stimulants. Give them too long or too high dose to people and you make them psychotic like you do with amphetamines. But then gradually the idea comes about that no, they're more specific than stimulants. They're doing something a bit different, and you get a range of drugs that actually doesn't have stimulant properties, and they start to be referred to as specific agents and as antidepressants. So over the course of the 1950s and 60s, you get this change in understanding of drugs from understanding them according to that drug-centered model to understanding them according to a disease-centered model. And I think you can see this change most clearly in the way that drugs are classified and named. So prior to the 1950s, they're just very crudely classified according to the different sort of states they produced into sedatives or stimulants. After the 1950s, they come to be understood and named and classified according to the disease that they are thought to treat. So from that time on, we start to get the names like antipsychotics, antidepressants, anxiolytics. And the classification of drug treatments is completely reorganized at this time and organized according to diseases. Now, this transformation does not happen because there is a lot of evidence that drugs are actually working on an underlying disease. That's a really important point to understand. There wasn't then, and there isn't now, any evidence, or there's very little evidence that drugs are acting in that way. What happens is that it starts to be suggested that drugs are working in this way, and people just start to forget that there was actually ever any other way of understanding what they might be doing. So, for example, In the early days of the introduction of antipsychotics, there's a lot of interest in the sort of alterations they produce, and people take them themselves, and they write about the experience of what it's like, how it makes them feel different, and they observe other people taking them. 20 years later, you've got nothing of that. No one is interested in that at all, and when we get the new generation of antipsychotic drugs introduced in the 1990s, you wouldn't know what sort of alterations they're producing, because no one thinks that that's an important question to ask anymore. Now, what sort of evidence might support this a disease-centered model, and why have we not got it? Well, the first thing to say is that most of the evidence that we base our use of drugs on consists of placebo-controlled trials. And placebo-controlled trials do not distinguish whether a drug is having a drug-centered action or whether it's having a disease-centered action, because you're comparing an active drug with an inert placebo. So that drug, if it's a psychoactive drug, is going to be producing alterations, and then it also might or might not be working on an underlying disease. The disease-centered model might be supported if we had good evidence of what does cause psychiatric conditions, and if we had evidence that the drugs were working to reverse those processes at some level. And as a very minimum to support the disease-centered model, we would want evidence that drugs that are thought to have disease-targeting actions are superior to drugs that are not. And it turns out, of course, that we don't have any of this evidence. We have some hypotheses for how conditions like schizophrenia and depression might be caused. And one of the most famous is the dopamine hypothesis of schizophrenia and psychosis, which suggests that these conditions are due to an overactivity of dopamine. This hypothesis came about because people noticed that some of the early drugs that were being given for this condition blocked dopamine receptors, and therefore, using the logic of the disease-centered model, they said, so the disease must be caused by the opposite of this. But actually, they're trying to find direct evidence that there are dopamine abnormalities has proved very difficult. And it turns out that actually, although some of the early drugs did have quite profound dopamine blocking activities, like the haloperidol there, with the dopamine blocking action is the yellow color. Some of the other drugs that are used as antipsychotics, including clozapine, which is this one here, which is regarded as being probably the most effective antipsychotic available, actually its dopamine blocking actions are relatively small compared to all the other brain chemicals that it's acting on and altering. And of course, I'm sure you're familiar with this idea that depression is caused by a serotonin imbalance. The earlier idea was that it was a monoamine imbalance, so because there are other monoamines as well as serotonin. And this is often depicted with this picture of the nerve and the synapses. It turns out that there has never really been any convincing evidence that there are serotonin or other monoamine abnormalities in depression. There was some work done on serotonin, on a certain class of serotonin receptors, which were thought to be relevant, and some studies showed that there were lower levels of these receptors in people with depression, but then more studies were done, and it turned out that some of them showed that people with depression actually had higher levels of these receptors, and some showed no difference, and basically the research is very inconsistent. There were some studies done which involved giving people a diet which is low in the molecule that's the precursor of serotonin, which is called tryptophan, and it was thought that that might produce depression in volunteers, but in fact it didn't. It seemed to possibly make depression worse in people who'd previously had it and been treated for it, but it didn't actually induce it. And there's a much stronger drug that induces a low serotonin syndrome in people, and that does indeed cause changes, but not depressive type changes. It actually makes people aggressive and hypersexual and irritable and paranoid. So there really is no evidence that depression is caused by low serotonin. What about evidence that psychiatric drugs are superior, that drugs that are thought to have specific effects on underlying conditions are superior to other drugs? Well, in the case of antipsychotics, there is some evidence that they might be superior to some other forms of sedative. Of course, that doesn't necessarily mean that they're working in a disease-centered way, because the psychiatrists who used these drugs early on in France, for example, they felt that the alterations that antipsychotics were producing were more effective than the sort of alterations produced by barbiturates. But actually, they don't look to be that different from other sorts of sedatives in the studies that have been done. So there was a comparison with opium, which showed that chlorpromazine, the earliest antipsychotic, was roughly equal to the effects of opium for people with acute psychosis. And there have been several studies looking at comparing antipsychotics with benzodiazepines. They're rather old, they're rather ropey studies, but they certainly don't provide evidence that antipsychotics are superior. If anything, they seem to mostly show that benzodiazepines were a bit better. Just skip over that. If you think about antidepressants, the evidence shows that any substance that causes a mind-altering effect, that produces some changes in thinking or behavior or emotions, seems to be slightly better than placebo or comparable to antidepressants for the treatment of depression. So as well as classical antidepressants, things like amphetamines, benzodiazepines, lots of antipsychotics and opiates have all been shown to be effective in depression in randomized controlled trials. So if we think about using a drug-centered model to understand how drugs are working in mental health problems, what does that actually mean? How does that mean they might be working? And so the first possibility is that there is an interaction between the alterations that the drugs are producing and the symptoms that people are having, the difficulties people are having with their behaviors or thoughts or emotions. But the other thing that I think we need to keep in mind is that there are, of course, placebo effects. People often feel hopeful when they're offered a drug, and that can help them feel better in itself. And if they get a drug that produces a few side effects and they know they're on something real and active and haven't just got the placebo, that can produce amplified placebo effects, even stronger placebo effects. So if we're going to approach the use of drugs for mental health problems in a drug-centered way, what we need to know is much more information than we currently have about all the changes and alterations that drugs produce. All the mental changes, also the physical changes, what they do in the long term, how those changes pan out what they do in the short term and how those changes pan out in the long term, because sometimes it's different. If you keep taking a drug, the body will adapt to its presence, and the effects that it has immediately don't necessarily continue. And because of that as well, when people stop taking a drug, they can often get quite profound withdrawal symptoms. So we need to know also about withdrawal effects. And when we've got a really good picture of what sort of effects a drug might have, we can then ask whether those effects might be useful in a particular individual's situation. We also, of course, need to ask, even if there are some useful effects, do they outweigh the adverse effects of taking an active substance? And are there alternative ways of dealing with the problem? So just to take a couple of examples of thinking like this about some of the drugs that we already prescribe, I'll start with thinking about antipsychotic drugs. These are the drugs that were introduced for the treatment of psychosis and schizophrenia, or at least that's what they became associated with. So we do have quite a few animal studies and healthy volunteer studies which have looked at the sorts of alterations that these drugs produce, and they're very consistent, and they show that consistent with the idea that these drugs are nervous system suppressants. They reduce things like movement, attention, reaction times, learning and memory abilities, and they reduce activity levels. And subjectively, people say what they feel like when they've taken them is that they feel sedated, tired, and they feel that they lose their emotion, that they lose their motivation and their drive and their initiative and feel sort of emotionally flattened. And these were the effects, as I suggested earlier, that were observed by the first psychiatrist that used them, the French psychiatrist, including this man, Pierre Dennecker. So his idea was that what these drugs were doing was basically inducing a new sort of neurological syndrome, which was a bit like Parkinson's disease, because a lot of the early drugs gave people symptoms of Parkinson's disease, made people very stiff and rigid. And he felt that this neurological syndrome was effectively replacing the mental health problem that the person had, effectively replacing the schizophrenia or the psychosis. And he felt that the emotional suppression was what was particularly useful about the effects of these drugs. And he said that what happens was that people who were really preoccupied by their delusions and maybe their hallucinations and other psychotic symptoms just lost interest in them. It wasn't that the symptoms necessarily went away, but their emotional response to the symptoms was dampened down. And if you ask patients today what sort of effects these drugs have, they will give you similar answers. Say that they feel stagnant, physically and mentally slowed up and restricted, and emotionally empty. I don't want to give the impression that all these drugs are exactly the same. They come from a variety of chemical classes, and there are differences between the individual agents. And a drug called olanzapine, that's the brand name is Zyprexa, is a little bit different from some of the others, and it seems to it still causes this emotional indifference, but that effect seems to be intimately connected with its effects on appetite and eating with this particular drug. So this quote captures it well. "I was in a constant fog of lethargy and indifference. I didn't care about anything. I just wanted to sit around and eat." And a lot of people who've taken that drug will say that they just become obsessed with eating, and eating particularly bad food, junk food. And these sorts of effects also seem to be intimately connected with the therapeutic effects of the drug. They're not separate. It's these effects on emotions that are dampening down the symptoms of psychosis. So people talk about how the drugs help reduce the intensity of their symptoms, dull them down, numb them a bit. I think this quote summarizes it really well from someone who was taking haloperidol for a psychotic episode, and she says, "Although I felt very well, I felt as if I had absolutely nothing to talk about. I kept wondering about whatever it was that had been so interesting during most of my life that I had suddenly lost. But I was very much in contact with reality, and for that I was thankful." I think that captures brilliantly how the dilemma that people are in who are undergoing an acute psychotic episode. I think that these drugs can be useful in that situation. If someone's mental life has been taken over by psychotic preoccupations, it may be useful to have that damped down to the extent that people can start to join in with the real world again. However, we should remember that some people get through an episode of psychosis without taking antipsychotic medication. So they're not necessarily necessary for everyone. But long term, I think you can see that these sorts of effects might be really impairing and might outweigh any advantages that the drugs have in suppressing symptoms. However, the standard treatment for anyone who's had a psychotic episode, or at least more than one psychotic episode, is to put people on long-term treatment. And most people who've had this diagnosis end up on these drugs for years and years and years, and often for the whole of their lives. And that is based on studies that have taken people who are already on long-term treatment and randomized some of them to go on to placebo. And these studies find that the people who are put onto the placebo tablet have a higher rate of relapse. But there's other evidence that shows that people who, naturalistic evidence that's just followed people up, that shows that people who avoid taking long-term treatment seem to do better. So the dotted line here is the people with a diagnosis of schizophrenia who've not taken long-term treatment, and they're much more likely to make a full recovery. The trouble with these naturalistic follow-ups is that that might be at least partly due to the fact that the people who avoid long-term medication maybe have the less severe conditions, and the people who end up on it have the more severe conditions. So we really need some randomized controlled trials with proper long-term follow-up to work out whether long-term treatment is a good thing or not. And there's one of these that's been done in the Netherlands. It was done with people who had just had one episode of a psychotic disorder, and they were randomized either to continue on antipsychotic treatment or to have a gradual reduction under the supervision of their psychiatrist. And how do I get back? There we are. And the first follow-up was at 18 months, and this follow-up showed that at 18 months, the people who'd had the gradual reduction were still a bit more likely to relapse than the people who'd stayed on long-term treatment. So the initial report from this study was just, oh, it's the same as all the other studies. It confirms everyone should be on long-term treatment. They then did a 7-year follow-up. It took them 7 years to get the money to do a long-term follow-up. And what they found is that at 7 years, the relapse rates had equalized between the two groups. So the group that were randomized to the gradual reduction, as you can see, initially, that's the black line, initially they have more relapses, they're less likely to remain well. But then the two lines come together, and actually the maintenance group do slightly worse by the end of the day. And then the other really important finding from this long-term follow-up was that the people who'd been randomized to have the antipsychotic reduction had a much higher chance of making a full social recovery. Their symptom levels were the same, but they were doing better. They were functioning at a higher level. So that suggests, and I think, you know, if we look at the alterations that antipsychotics produce, we can understand why that might be. It suggests that these alterations are not, you know, not helpful to people who are trying to go about their daily lives. Other reasons why we need to be very cautious about the prescription of these drugs, particularly long-term, is that they have really serious adverse effects. We know that they cause weight gain, they cause diabetes, they interfere with glucose metabolism and fat metabolism, particularly some of them more than others, like olanzapine, as I said earlier, but they all do so to some extent. And then recently there's evidence come out that they cause atrophy of the brain, essentially, reduction of brain volume. And this has been shown in studies with animals, where they've compared animals who've been put on injections of antipsychotics with animals that have put on placebo injections. And after 18 months of treatment in this study with macaque monkeys, the brains of the monkeys who'd had the antipsychotic treatment were 8 to 11% lighter. So it's quite significant. Apparently, I met the man who did this study last summer, and apparently 18 months of the lifespan of a macaque monkey is equivalent to about 6 years of a human lifespan. So it might take longer in a human to get to that level of atrophy. Nevertheless, it's still quite significant. And looking at human studies, you can see there's a strong correlation between the amount of time that people have been taking these drugs and the amount of brain volume reduction that they're showing on MRI scans. We don't know whether that brain volume reduction affects people's intellectual abilities. It's quite possible we can lose quite a lot of our brain without it mattering too much. There are some studies that suggest that it is associated with some cognitive impairment. Some suggest that it's not. But we do know that long-term antipsychotics can cause cognitive impairment as part of this syndrome called tardive dyskinesia that they produce. This is a neurological syndrome where people get abnormal movements, but associated with the abnormal movements, they get some cognitive decline. There's a Greek rock band called Tardive Dyskinesia I discovered, and that's one of their album covers. And tardive dyskinesia, it's often said to not be as common as it was before, but recent studies suggest that it does still occur quite frequently, particularly in older people. And the other important thing to say about antipsychotics, the other major disadvantage, is that most people find them very unpleasant drugs to take. Some people find them really, really intensely horrible. So these are sort of typical quotes from people. They feel like they're in a drug prison, a living hell. And the photograph is from a protest that people had against the forced use of these drugs. So in people with psychosis and schizophrenia, I think sometimes there are grounds to use antipsychotics when people are acutely psychotic, but whether or not they're a good thing in long-term treatment really, to my mind, needs further research, because they have such serious adverse effects. We really need to be certain as to whether there are any benefits. I was given some money from the British government to do a large trial, a sort of larger version of the Dutch study, to look at the long-term effects of maintenance antipsychotic treatment compared to a gradual reduction regime. So I'm hoping in a few years to have some more answers to the pros and cons of long-term treatment. But that's all for people with a really serious mental disorder. And one of the most worrying things is that these drugs are increasingly used for people with less severe conditions. They're increasingly prescribed to people with depression, anxiety, even insomnia, and to the widening number of people that are now given the diagnosis of bipolar disorder. The expansion of the diagnosis of bipolar disorder has partly been brought about by the pharmaceutical industry in order to widen the market for their antipsychotic drugs. So bipolar disorder used to be called manic depression, and manic depression was and still is a very rare condition. It probably occurs in less than 1 in 1,000 people. David Healy did some research on the incidence rates in Wales back at the beginning of the 20th century. And it's very characteristic. People become highly aroused, manic, their behavior is really very extreme, they usually end up in hospital, and it goes on at least for weeks and often for several months. But starting in the 1990s, there started to be suggestions that maybe there were less severe versions of this condition, and people proposed the idea that there was bipolar 2, which was people having sort of subclinical manias alongside ordinary episodes of depression. And then there was this idea that there's a bipolar spectrum disorder and that some people have a sort of bipolar type personality. The pharmaceutical industry latched onto this, and this cartoon here is not too much of an exaggeration. And they started to produce these bipolar screening tests, which include things like, questions like, these are real questions from one of the tests. Does your self-confidence range from great self-doubt to equally great overconfidence? Are there great variations in the quantity and quality of work you produce? Do you have periods of dullness and other periods of creative thinking? Clearly, these are questions that all of us would say yes to at one time or another. So what the pharmaceutical industry have managed to do is create a syndrome, which they called bipolar disorder. It doesn't really have any relation to the original bipolar disorder, and it can be applied to anyone. And these are just examples of advertising. So here's an advert emphasizing the idea that bipolar disorder is about mood swings, about up and downs of mood on a sort of daily basis. And another one for advertising an antipsychotic for bipolar depression. Just in the last few minutes of me talking, I'd just like to say a few words about antidepressants, because I want to show you how this idea of the drug-centered model applies to other sorts of drugs that we prescribe for mental health problems. And the first thing to say about antidepressants, which should shock us, is that there is almost no research on what sort of alterations they produce in volunteers or in animals or in people who've taken them for mental health problems. That just no one's been interested, because there is just this idea that what they're doing is reversing a serotonin imbalance or treating a disease in some way. For some reason, however, there have been some studies done giving pregnant animals doses of SSRIs. And what these show, and this is a review of several of them, is that the offspring of these pregnant animals show changes in behavior such as these: reduced sexual behavior, decreased exploration, decreased social interaction, and in some of them show some increased anxiety, or agitation, overactivity. Those may be long-term effects of the drug, or they may be effects of drug withdrawal. It's not really clear, but it suggests there definitely are some alterations going on when you give animals and humans these drugs. And they also are consistent with how people describe the altered state that these drugs produce. Now, this was a study I did looking at people's descriptions of taking SSRIs. I should say that the effects of SSRI-type antidepressants are very much less marked than the effects of taking an antipsychotic. So you can take a dose of Prozac, for example, and not notice any difference at all. If you took a dose of haloperidol, you would know it immediately, or as soon as the drug gets into your system. So they're much weaker drugs in terms of their psychoactive effects, but nevertheless, they do cause some alterations, some quite subtle alterations, and these include sort of feelings of listlessness, feelings of, again, of sort of emotional blankness, disengagement, restriction of some sort. And these effects seem to be associated with a loss of libido, which is very well recognized that they cause sexual impairment. In a smaller group of people, mostly younger people, they also seem to produce a state of agitation and increased tension and irritability, and it's this state that seems to be associated sometimes with suicidal feelings and possibly with aggression, some recent reviews have shown. So the question is, are these effects useful? I think if you look at them like that, you'd struggle to really feel that they were useful. What the placebo-controlled trials show is that antidepressants are barely any different from a placebo in terms of when you look at people's scores on depression outcome measures. And those differences are undetectable when you look at other ways of looking at it. So just get this graph up. So this is comparing ratings on the Clinical Global Impression Scale. So that's a general impression of someone's level of improvement with changes in the Hamilton Rating Scale. So someone who has a 3-point difference in the Hamilton Rating Scale doesn't show any change. You can't detect any real overall change. You have to have at least an 8-point difference in the Hamilton Rating Scale for depression in order to be considered to be minimally improved with this global rating scale of improvement. And the placebo-controlled trials show a 1.7-point difference, around about a 2-point difference if you add in all the negative studies that aren't published between placebo and the Hamilton Rating Scale. And that sort of, so that sort of difference is basically not clinically relevant, and also quite possibly accounted for by amplified placebo effects by the fact that the people taking the active drug know that they're getting an active drug. So this lack of effectiveness is confirmed really by naturalistic studies such as the STAR-D trial, which was a trial that enrolled a whole load of people with depression. It didn't have a placebo group, but it involved giving people a series of different antidepressants, and when the data was analysed properly by someone who was a bit more sceptical than the rest of the team, it was clear that the number of people who actually got better and stayed better on antidepressants was absolutely minuscule. That's that tiny little column in the middle there. And lots of people, some people got better, but lots of people then relapsed again, or they just dropped out because they were fed up and it wasn't working. This is a study that shows that antidepressants people who take antidepressants are less likely to get back to work, people who are having a period of sick leave. So the percentage of people who return to work is higher among people, these are all people with depression who don't take antidepressants. Of course, this may well be to do with the fact that their depression isn't quite as severe, but I wanted to show you this because this study was reported as showing that antidepressants help people get back to work. I can't remember how they did it now, but they used some sort of statistical means to show exactly the opposite of what they'd actually found. This was just a study of disability benefits that I did recently, which shows that as antidepressant prescription levels have gone up, the number of people on long-term disability for depression and stress and other sorts of disorders has gone up too. So they're not helping people get back to work or get back to productive lives. Antidepressants probably don't have quite the same scale of adverse effects as antipsychotic drugs, but they do rarely have some quite serious complications. And one of these, which is starting to come out, but there's not been very much interest in it in mainstream literature, is this idea that they can cause persistent sexual dysfunction. So we know that they cause sexual impairment while you're taking them in a large number of people, probably at least sort of 50-60%. But what is coming out is that in some people who stop taking them, that sexual impairment continues, often for a good few years. And this evidence is coming from, not from mental health or psychiatry, but from sexual health clinics, where they're increasingly seeing people who've been on these drugs and are coming along with complaints that their sexual function is still not what it was before they took the drugs. They cause withdrawal effects, and again, in a small number of people, those withdrawal effects seem to be really protracted and really difficult and can go on for months and possibly for years. And there's been lots and lots of debate about whether or not they increase suicidal behaviour and thoughts. And I think the evidence is now fairly conclusive that in young people particularly, they do seem to have this effect in a small number of people. There's also some evidence they cause fetal malformations. And I think the psychological effects of antidepressants are really important to acknowledge as well. When someone's given a pill, when someone's unhappy, probably got lots of problems in their lives, and they're given a pill as the answer to that, there's a message that goes along with that pill that says the problem is in your brain. You can't address it, you need the pill to address it. Even if the doctor is also saying, oh, you must also go to therapy, you must also do this, also do that, the pills carry this strong symbolic message. And the other issue is that if the pills are altering your mental state, dampening down your emotions, making you a bit lethargic, you may not be able to sort out the problems that led you to seek help in the first place. So if we're going to use antidepressants in a drug-centered way, this is the sort of information that I think we should give to people. The standard view, the standard information that's given at the moment is, take an antidepressant, it'll help rectify your serotonin imbalance, or at the very least people are told, it'll improve your depression, with the implication that it's going to work on the source of the depression. If we were taking a drug-centered view, we'd be saying to people, we've got these drugs that affect the way that people think and feel in some way, although we don't know much about this because we haven't bothered to research it. But what we do know is that they dampen down emotions a little bit, they're going to impair your sex drive and your sex life, probably sort of make you feel a bit demotivated and lethargic. And then we could ask people if they wanted to take them or not. And you know what? Some people would say yes. So just quickly before I finish, I just want to think about why it is that this disease-centered model of drug action has become so dominant and has eclipsed our understanding of the alterations that drugs produce. And I think it's because it serves the interests of three powerful groups, and these interests come together. And those interests are the interests of psychiatrists and the medical profession, the interests of the pharmaceutical industry, and the interests of the state. So professional interests. The psychiatric profession has been trying, since it first came into existence in the 19th century, to prove that they're real doctors and they're dealing with a real medical problem. And of course, the idea that their drug treatments are treating an underlying disease helps support that view. It was really particularly important to put this view across in the 1960s, when the disease-centered model of drug action really sort of coalesced. And that was because there was an increasing problem of recreational drug use. And the drug culture of the 1960s started with the diversion of prescribed drugs. That's something I was not aware of until I started reading about it. This is a quote from a US senator about how the pharmaceutical industry's multi-million-dollar advertising budgets, frequently the most costly ingredient in the price of a pill, have, pill by pill, led, coaxed and seduced post-World War II generations into the freaked-out drug culture plaguing the nation. In 1970, 5% of Americans were prescribed amphetamines. So that's what he's talking about. And so it was necessary for doctors to distance themselves from that and say, you know, we're not just giving people drugs to make them feel high or to put them in an altered state, we're giving them proper disease treatments. The pharmaceutical industry were quite comfortable with the drug-centered model up until the 1980s, because there are a lot of people who want to take something that makes them feel different, so they had a big market. And they were doing very well selling their drugs like Valium and things like that. In the 1980s, it became apparent that millions of people, especially women, were being put on benzodiazepines like Valium, basically to keep them quiet and stop them complaining. And it was obvious that they were not as safe as they had been portrayed to be. They were definitely addictive. They'd been marketed as something that wasn't addictive. And so there was a big scandal about that. And the pharmaceutical industry then needed to make sure that people didn't think they were doing that same sort of thing again. So when their next blockbuster drugs came out, those were the SSRIs in the 1990s, they made sure that those drugs were marketed alongside the idea that these drugs are being given to treat a disease. And I think the usefulness of this idea is summed up in this little quote from Eli Lilly's website as well. Antipsychotic medicines are believed to work by balancing the chemicals found naturally in the brain. So olanzapine is this drug that makes you put on loads and loads of weight. You can see how unnatural this drug is just by looking at someone who's taking it. But this makes it sound as if it's practically homeopathic. And this view, you know, made antipsychotics seem so benign that they were even advertised for children. Here's an advert featuring a girl of, 12, 13 years old. There was this idea that you have to prescribe them as quickly as possible in order to prevent people getting unwell. And this culminated in the scandal of pediatric bipolar disorder, where antipsychotics and other drugs were prescribed to children with behavior problems who were basically who were given this label of bipolar disorder, again helping to expand the market for these very toxic drugs. And this is Rebecca Riley, who sadly died at the age of 4 on a cocktail of 4 or 5 different sedative agents, including an antipsychotic, and had been given that diagnosis. But I don't think pharma, and certainly the psychiatric profession, would have been able to be as influential and to have put this message forward if it wasn't also convenient for governments, a convenient message for governments. And it's convenient because seeing psychiatric treatments as a disease treatment allows us to paint things like the restriction and forced hospitalization of people with mental health problems as a benign activity, as treating a disease, as a nice therapeutic endeavor. And of course, we don't just forcibly put people in hospital anymore. In the UK, and I know in a lot of states in the US as well, people can be forced to take drug treatment who are in the community. So those people are often functioning reasonably normally. They don't need to be in hospital. They can certainly look after themselves outside hospital, but we are forcing them to take drug treatment that they don't want to take. And the point about the disease model of drug action is it allows us to see this as as a benign, as a therapeutic endeavour. And as Thomas Saz put it, we don't need to feel guilty about it. Takes the guilt away. So, just to sum up very quickly, and then hopefully we've got some time for questions. The disease-centered model, this is the idea that drugs are working by targeting an underlying chemical imbalance, assumes that giving drug treatment is a good thing. Doesn't mean you should always do it, but it assumes you should do it unless there's a good reason not to, because of course you're curing an underlying disease, you're helping to normalize the body in some way, so why wouldn't it be a good thing? And that's partly why there's been this huge expansion in the use of drugs for mental health problems that we've seen recently. The drug-centered model highlights that drugs are chemical substances that alter and modify the way that the brain and body normally work. So there are inevitably dangers associated with taking them. So this model should, I think, if it's applied, lead people to be much more cautious about the use of these drugs. As I said at the beginning, I think there are some situations where they can be useful, but many, many situations where they do much more harm than good. Okay, so thanks very much. So do you want the microphone?
Hi, is this on? Yeah. Thank you very much for your talk. I had a question. So do you have any suggestions as far as for people who have been diagnosed with bipolar or manic depressive? Do you have any suggestions on what they could do outside of the drug-related therapy?
Well, it depends what sort of bipolar or manic depression. So for people who have classical manic depression, who have these episodes of mania, I think they need to have treatment or be in a safe place when they have their manic episode and be looked after, and some sedative drugs of one sort or another are probably helpful, because often people just don't sleep for days or weeks at a time. And then I think it's a case of trying to help people identify when they might be getting another episode. And usually over time, as people get older, they get better at identifying when an episode's coming on, at finding ways of dealing with it. So if it's that sort of bipolar disorder, that's what I think needs to happen. As I said, the label is now applied to all sorts of people, and it really making recommendations about people who have a different sort of condition, I think, is an individual thing. You need to look at what sort of problems they have and how else they can deal with them. And it might be, I think a lot of people do have trouble managing intense emotions. I worked for a few years with addicts, and a lot of people are using opiates or alcohol or all sorts of other things to avoid feeling how they really actually feel. And I think all you can say about that is learning how to cope with our emotions and where they've come from. Is not a quick fix. It can't be done overnight. It's something that people need to learn probably over years, and probably using lots of different techniques, maybe therapy, but maybe many other things too. I think there was some. Oh, sorry. Have you got yes? Yeah.
Yeah, I just wanted to, because from what I saw, you get into a lot of studies, and a lot of these studies had numbers and everything. Just want to know, how is it considered, the studies, with a person's diet, and what's their lifestyle? Are they being treated psychologically, to try to calm down, or are they just given drugs? Sugar, is that still considered as part of these studies, and what the actual lifestyle of the person is before they start interacting with a medication? Yeah,
so no, none of those things are considered in any of these studies. And I don't know any research that's been done, or much research, because I think there is some on omega-3, but I think there's very little research into diet and the effect of diet on mental health problems. There is good research on exercise. There's quite a few studies on the role of exercise in depression, and exercise is easily as effective as antidepressants for most cases of depression. There was a lady down here. And then there were some hands over there.
Thank you. When did they stop administering electric shock therapy in England, and are they still doing it today here? And is it voluntary, or can it be given involuntarily?
So it's still given in England, yeah, but the latest guidelines, which came out probably about 10 years ago now, did make it much more difficult to give it against people's will. So it's not given very often against people's will anymore in England. I don't know the situation in the States, but I do hear that it's used more commonly here, partly because it's a sort of quick form of treatment that health insurance companies might like, because you can say, okay, you can have 10 weeks of that, and then it's done.
Does it affect heart attacks? Is there a correlation of heart attacks with the electric shock therapy?
I don't know. I'm sorry, I don't know whether there's an association with heart attacks. I mean, the main side effect we hear about is loss of memory, which was always said to be temporary and not really very significant, but actually there's a lot of evidence that it can be permanent for some people, and some people it's really very distressing and horrible. I think there was some sort of in the middle over there.
Thank you again for your talk. Very informative and enlightening. Are you familiar with the work of what Dr. Amen does? He and also as it relates to, instead of his philosophy is looking more at nutrition, food, and that instead of using drugs or looking at cluster of symptoms. He's ones that will look at. Are you familiar with his work?
No, sorry.
They will look at brain scans. It's a SPECT scan. And
Yes,
so they're
yes,
looking
I've
at the
heard- yes,
brain.
yeah,
Instead of
yeah.
just looking at symptoms, they're looking at the brain and they're seeing blood flow and brain activity and making it. But I just, what's your take on, obviously you're saying there's limited studies about nutrition, they've said exercise has been proven, but nutrition, food, and supplements helping as another route versus the synthetic, chemical drugs.
I'm sorry, it's not really my area. All I would say is that, I think it's really important that people eat well and healthily. It's part of looking after yourself, and that's part of what is going to improve your mental health and help you, yeah, and give you confidence and self-esteem. There was a man over there who's had his hand up for a while, and then a lady in front of him, and then, sorry, yes, some people around there.
Thank you very much for coming today. It seems like we're just all addicted to drugs, whether it be coffee or sugar. This gentleman was speaking about sugar, and I'm a little bit in that field with the alcoholism. And it seems like to me, a lot of alcoholics and drug addicts, they love highs, whether it's coffee, carbs, and there is a mood swing. There's an extreme mood swing. So we like to be in another place in our mind. And they need to do a lot more studies in this area because it all turns to sugar. Carbs turn to sugar. So I want sugar. I want this high. I want to go in another place. So they need to do a lot more studies in this area because it's really, it just also speaks on how much corruption there is with monies in this whole this whole system. It's all corrupt. So thank you very much.
There's a quote by Aldous Huxley, a brilliant quote, which goes something like, we all want to have chemical vacations from the intolerable reality of our lives. I think that's true. And I think the way to reduce the damage of those chemical vacations is first of all to realize what we're doing and to try and do it as harmlessly as possible. And secondly, to try and reduce the intolerable reality around us, to try and build up lives that are better, that we don't need to escape from quite as much. Where's the mic gone? There was there's some people around there. There's a lady there who's had her hand up for a while.
I just wanted to say, you know, watching this as a parent of a young adult who was diagnosed with bipolar is very depressing. We finally have found what we felt is, you know, drugs that have helped my daughter reduce a lot of the suicidal thoughts, and I'm feeling now with, like, she's doing the Prozac and the lithium and Abilify. Obviously, when I first started to put her on that, you cringe at the thought of giving your child, no matter how old they are, anything that may harm them. And I do see the adverse, you know, effects that you talk about. But besides the therapy and, you know, she struggled with going off them constantly because of the effects. And it's sad to see what is going on, you know, in her mind, and how she constantly would say, I don't know why I feel this way. But what, as a parent, you know, I said, this isn't a life sentence, you know, I hope that she'll be able to get off the drugs. But again, what is, personally, what, if she was a patient of yours, what would you suggest? She is doing the pills, she is doing the therapy and the group therapy. What would be something else that you would suggest that would be helpful?
Well, you know, I think sometimes people do feel that they're getting some benefit in a crisis out of drug treatment, and I don't think there's any point then sort of making them feel bad about it or forcing them to stop. I think it's then important that people do other things like therapy. I suppose trying to deal with what was wrong in life and make that right again, and then hopefully when they're in a better place they can start to come off. And that's what sometimes you have to take the focus away from the drug treatment actually for a while, stop worrying about it, get other things in place, and then, as you say, what's really important is for people not to feel that this has to be forever, and always to feel that, you know, there will come a time when they will be in a place where they can reduce, but not to feel that they have to do that immediately if they don't feel they're ready for it.
So much. In the mental health profession, I'm currently treating a lot of patients for different diagnoses, and I just wanted to see if there was any studies that you had seen that the effects or long-term effects of these diagnoses as far as depression or anxiety within the aspects of the medical problems that people can exhibit. For example, like anxiety, you know, attributing to heart disease and heart attacks, because there are symptoms that the patient will have as far as like the heart rate beating fast, you know, sweaty palms, the entire physiological symptoms of a person changes once they do have different symptoms of anxiety and depression. So I'm just wondering if there are any studies out there that show any correlation with physical illness.
Yes, there are high correlations between having particularly chronic physical illnesses and depression, probably between heart disease and anxiety, but I couldn't swear on that. It just sort of seems to make sense, doesn't it? But certainly there are studies showing the coexistence of physical diseases and depression. It's been another sort of area for marketing antidepressants, you know, targeting people in hospitals. Whereas, of course, you can understand if people have got chronic physical conditions that they're more likely to be depressed. They're less likely to be able to do the things that previously made them happy. So I don't think that antidepressants are a logical answer, but that's how it's been approached. Where's the mic gone?
Hi. Yeah, a lot of these antidepressants, one of their main side effects is suicidal tendencies. And some of these mass shooters that have been happening have been on these antidepressants.
Yeah, so I mentioned that briefly. So they do seem to, I would say in a relatively small proportion of people, but it's more common in younger people apparently, cause this sort of state of agitation and tension, and that can be associated with suicidal feelings and with aggression. And there's just one big review that's been done recently that's highlighted the link with aggression. It's always difficult in the case of an individual who does something to know whether it was the antidepressants or whether the problem was there before and that's why they were prescribed antidepressants. But studies that have looked at randomized trials have shown that these suicidal thoughts and aggressive tendencies are more common, slightly more common in people taking the antidepressants compared to people taking the placebo. Again, it might be very rare, but obviously it's a very, very serious side effect. And if it's true, as I'm saying, that really these drugs don't have any benefit, I feel that that's enough that we should really stop using them. I can't remember. This lady over here in the pink cardigan's had her hand up for quite a long time.
I have two questions. One is about SSRIs. What is your I've been told, because I'm on one of them, about having bone loss. And as if you stay on them consistently, does the bone loss continue to get worse?
I'm really sorry, I don't know. I don't know the research on bone loss and SSRIs. I'll look it up.
Okay. The other question is about OCD. You didn't talk about that at all. In terms of treatment, do people stay on drugs for that for a long time? Does it work?
Again, I'm afraid it's not a body of literature I know very well, but just thinking sort of logically about the effects of SSRIs, it's possible if they've got this sort of emotion dampening effect that it might help with OCD, that if people are, that it might dampen down the anxiety enough that people don't feel the need to go through the obsessional rituals that they go through. So I can see some sort of logic of why they might be beneficial, but I haven't looked at the trials in a lot of detail, I'm afraid. This man's had his hand up for a while.
Thank you. Is this on? Yeah. Okay. I got into a tremendous row with one of my scientist sons about, there had been, there's been a couple of very, very prominent mass murders and shootings and things like that. And what had happened is that there was all this usual hullabaloo about the guns. It's the guns. But somehow I got a website or something like that from a gun supporting organization that commented that everyone, apparently somebody did a lot of research, I don't know how they did, found out that all of these people that committed these heinous crimes were on this kind of drug, mind-altering drugs. Now, it makes me think about, well, either it didn't work or they made something even worse. But it's, the correlation was, like hundreds of cases. The guy did. The one that blew me out of the water was that a couple of years ago, some young man stole an airplane and crashed it into a office building in California. And, what is this? That kind of thing. But again, the correlation seemed to be some connection with these mind-altering drugs that were presumably trying to help him with something.
Yeah,
so there's a dark side to this.
Yeah. As I say, the problem is that people who are disturbed in the first place are probably more likely to get put on these medications. But as you point out, at the very least, it suggests they haven't been helpful for them. Yeah.
So if it's not nutritionally, if it's not an origin of nutrition, that's an issue, which is what this whole conference is about. But if that's not the origin, when you're talking about bipolarism or manic depression, what would you consider the origin, and what percentage of the population do you think that is?
So to deal with the numbers first, the percentage of the population who have serious manic depression or schizophrenia or psychosis is fairly small. Schizophrenia, psychosis, it's said to be about 1%, it's probably a bit less than that. And manic depression is much less common than that, the sort of classical form of it. What do I think causes it. I don't think that we'll ever know. I think it's too complicated. I think it is just a way that some people are. I don't think we'll ever be able to pinpoint it either in terms of brain chemicals or brain connections or in terms of nutrition. What we do know is that people are much more likely to get these diagnoses if they've had sort of major traumas when they were growing up, or difficult circumstances. But that's not the case for everyone, so that's not always the cause. Lady there.
Thank you so much. Just actually a secondary question to the nutritional question. Do you have any thoughts on genetic mutations and certain kind of knowledge that genetic mutations affect either aminos or neurotransmitters, and lack of that could be causing these problems? Or is that too cutting edge?
Well, lots of people have been looking for the genetics of schizophrenia and the genetics of depression for decades and decades. And what the latest research shows is that there are a huge number of genes, hundreds at least, that increase your risk of getting one of these conditions by a very, very small amount, sort of less than 0.1%. I don't think that sort of adds up to much. I don't think that really tells us very much. All it seems to say to me is, well, we're all different. We've all got a different set of genes. We've all got a slightly different risk of getting everything. So that's what the genetic research shows so far. I don't know whether people have sort of specifically investigated the genetic basis of different, metabolic pathways. Not so far as that they found any definite connections. Anyway. Hi, yes, sorry. Who've you spotted?
Hi there, I'm Dr. Garinger, and to respond to the genetic part, there's actually a company called Pathway Genomics. So these patients are placed on these antidepressants, and we're able to, with technology, we're able to go and find out where the mutation comes from. And you're able to check the drugs and see the interaction between the drug that these patients are being placed on and how their body metabolizes it. And the sad part is that these genetic mental health testing is covered by your insurance. And I mean, at my practice, we don't do insurance-based just because we're very preventative, and of course it's not covered. But these, I feel like every single therapist that have to put these patients on these medication need to genetically test them and see if they're able to metabolize these medication to lessen the side effects. Please check on genetic mutation. I know there's a lot of stuff out there, so hopefully that helps somebody.
Yes, thank you. So that's the idea that that there is individual variation in how we metabolize drugs, and we can look at that to a certain extent genetically. And yes, it's very useful because that means we can tailor the dose of things according to how people's bodies can manage it. Lady there.
Hi. And what about the use of weed that increase your risk in getting schizophrenia too, right?
The what, sorry?
The use of weed.
Weed?
Yeah, it's also increase your risk to get schizophrenia in long term. But my question is, what happened to the brain when you use morphine or codeine? Nowadays is everywhere, when you go to the dentist, when you go to the emergency rooms, they're giving you morphines to stabilize it. And I am a doctor in Mexico where you use that. Morphine is for cancer patients. Morphine is for higher pain. And here, they're using for a simple abdominal pain. So I want you to explain as a psychiatrist what happened when you use the first time morphine, what happened in your brain, and it gives you risks to be added, or if it's in long term, you know what I mean? So thank you.
Yes. I'm not sure that I would say that, one dose of morphine makes you an addict, but I think there are lots of problems with the widespread prescription of opiates that there is in this country. I mean, we know there's, it's one of the highest causes of death in young people now, isn't it, here? I mean, it might be the highest cause of death, I think. So it's I think, a very bad and shocking practice that so many opiates are being prescribed. Yes, they have lots of psychological, psychiatric complications, but they kill people too. Should we have one more question and then shut down? It's 1 o'clock. I'm sure people are hungry. One more question. Who should take you?
Hi, thank you so much. I know we've been talking a lot about finding the root causes, and a lot of the times people just want to escape their inner brain and their inner thoughts. And something that I'm really passionate about is, like what you were saying, finding the root cause and trying to change the way your inner voice is. And I guess just to some people who are having questions maybe about like family members, or if they're struggling, like trying meditation and practices like that. I'm not sure if that's in your area of research, but I know there has been a few good studies on it, and it's been like proven to be very well. I was just wondering if you've seen any research on meditation and mental health.
I don't know, but I work with a colleague who's got a very strong interest in it and who's currently doing a study of mindfulness. And I know that there are several studies of mindfulness and meditation and mental health problems. I think it leads to a really important point. There are lots of aspects of modern day life that are going to make many people mentally ill. We live in a terribly competitive society. Everyone's working all hours. We don't, have enough time to look after ourselves, to do nice things, to interact. We're often a long way from our family, friends. A lot of people don't have enough money, don't have secure housing, don't have secure employment. So there are lots and lots of things that are going to increase people's risk of getting mental health problems. And I think anything that people can do we need to change society and deal with some of those root problems. But in the meantime, things like meditation and looking after yourself and having a good diet and exercise are all going to be helpful. Thank you.